I'd now like to invite Dr. Jenny Hewitt, who's going to talk to us about this, who's a lecturer in allied health, clinical educator in physiotherapy at the University Centre for Rural Health in northern New South Wales. Jenny's going to talk about the Sunbeam program, implementing and delivering evidence-based falls prevention under ANAC, which is the funding system within residential aged care. Thank you. Thanks, Jenny.
Thank you. Thank you, and I also hark from outside of Sydney in a rural area. I come from Bundjalung country, far north New South Wales, and pay my respect to elders past, present and emerging from from all of the areas, the lands from which we are meeting today. I'm going to talk about the Sunbeam program a little bit, but beyond Sunbeam. So Sunbeam was performed mainly because I had a bee in my bonnet about ACFI. I worked as a physiotherapist and I had my nose out of joint that we were funded purely to do not strength and balance, the opposite, passive massage and TENS, passive pain relieving modalities, and there was no room for exercise. And so I undertook the project purely to see whether we could make a case, to generate some evidence, find some evidence. It was a risk, might have also shown that the exercise program made falls worse, which some of the exercise trials had at that point. So because of that, I had to make a choice about whether Anne Tiedemann, that we heard from this morning, Kathy Sherrington, had released some best practice guidelines, what is the best practice exercise for falls prevention, and it talked about high challenge balance work and strength work for people who were deconditioned. And I was working at the time, it's around 2010, with residents, and they were deconditioned for sure. They sit for about 23 out of the 24 hours, or maybe 22 hours on a good day. And so strength was important, but then to know whether the best practice guidelines of 2 to 3 sets of an individually prescribed strength program was actually being implemented, I chose to go with the gym equipment because that measured it for me, and it was a clinical trial. The downside, of course, is it's not scalable because then we don't know whether the same program works without the gym. So I'm going to talk to you about Beyond Sunbeam today. And ANAC, so ANAC is the new funding instrument, which I won't go into in great detail. I like to see the glass as half full, so where there's rays of sunlight peeping through here, or even though those of you who currently work under ANAC might be feeling the opposite, the glass half empty. And we'll talk about, as we're in this transition period, so ACFI's gone, we're no longer as Allied Health funded to do massage and TENS, but we're not funded to do anything in particular. So some aged care providers have decided to get rid of us. So we're in a transition period, but I'll talk to you about what I see as the opportunities that are heading our way, so that hopefully it'll be encouraging. So just as a little recap, as I said, and these purposely are old black and white pictures. I found the most outdated picture of a massage I could find when talking to government, and TENS machines. And that was actually the manual for ACFI, that cover you can see there, which shows how out of touch it was in terms of allied health in particular, but other things as well. So we were funded to do either 20 minutes or 4 lots of 20 minutes per week of TENS or massage. Now, a lot of us actually did what was best for the person in front of us as practising clinicians. A lot of us did what they needed and then just rubbed a little bit of heat rub on the end and ticked the ACFI box, or put a TENS machine on at the end. But, that's just not good enough. We're in Australia, we should be able to implement best practice and use the training that we've worked hard to get. And implement a person-centred approach for the person in front of us who has goals and aspirations, even if they are 99 or 100 years old. So under ACFI, there was no direct funding for contemporary pain management, because contemporary pain management isn't massage or TENS either, falls prevention, restorative care or rehabilitation. In fact, providers were actually financially incentivised to have a more disabled bunch of residents. They got more money the more disabled you were. I can remember one time the ACFI coordinator said to me, "Oh, here's that pesky physio who keeps getting people back up on their feet." Under ANAC, it's a new day. The key elements is a change of funding. It arrived last year in October. I won't go into the details, but it's basically aged care providers are provided with funding on a resource use classification system. So the more resources a resident needs, the higher the funding. But if they get them better, they get to keep that high level of funding now. So that perverse incentive has been removed. So that's one thing to celebrate. I went to the ACPA National Conference last year in Adelaide, which was about a couple of weeks after ANAC started, and there is increased funding, there is reduced administration. There is no prescription now for allied health services, so allied health services can officially provide residents with whatever is best for them based on an individualised assessment. But why aren't we dancing in the streets? I think, can I have a show of hands for who works as clinician in residential care? Yeah, so you will have no doubt come up to the against issues around the fact that the good thing about ACFI is that the aged care providers were provided with direct funding to have us there. And the bad thing about ANAC is that because they don't really have rules, and they're so used to working under rules and directives, they don't really know what to do with us. Care minutes is a Royal Commission recommendation, which you'll hear in the news a fair bit. So aged care providers are currently working towards around 200 minutes. It's changing a little bit of nurse or care worker time per resident per day. So you can imagine if you're working in a village or an aged care home that has a number of more ambulant residents, so they have lower resource needs. Under ANAC they get less funding, but they still have to provide 200 minutes of nursing time. That's why we're starting to see aged care homes close down. So this is under review, that's the good news. Let's not get the doomy gloomies. ANAC does not mandate or regulate allied health. They can choose how they spend allied health services. Providers can choose how they spend their daily rates. Most are struggling to meet that 200 minutes, and some of them have chosen to reduce our hours. But to be honest, I think 4 days a week of physio, OT or EP was too much. Can you imagine any other setting really, if you went along to see a physio for a sore neck and they said, you're going to have to see me 4 days a week for the rest of your life? You just go somewhere else. So I don't think that's any big surprise. Let's start looking at the glass half full end of this. Evidence-based allied health is what we're now asked to produce, and this is great. Exercise is best practice, allied health for falls prevention, even for chronic pain. So with education and reassurance, frailty as long as they've got adequate nutrition, hip and knee osteoarthritis, bone health, restorative care and reablement, neurological conditions like dementia and, like Parkinson's disease and stroke. So the fact that we're no longer doing TENS and massage for people with these conditions is very encouraging. And what is yet to come is that the government is still saying that allied health professionals play an important part, that they're required to, aged care providers are required to provide allied health, but we're still in the transition phase and the story is not finished yet. So I'm quite confident that as the Aged Care Quality and Safety Commission comes through and looks at what's happening in the aged care homes, if they're seeing staff numbers being reduced and allied health pushed out the door without implementing best practice of some description, then there should be a turnaround in time. Now, the Sunbeam is an example of best practice exercise. It did reduce falls rate, it did improve mobility, balance, and the ability to climb up out of a chair, so some functional scores. We did a subgroup analysis with Kim Dobar and Morag Taylor 2 years ago, and found, just looking at the people with a cognitive impairment, found it had a good result for them too, and it was cost effective. These are all key recommendations from the Royal Commission. The Sunbeam program included progressive resistance and high challenge balance work. Everything was individually prescribed. They did 2 one-hour sessions for a 6-month period per week and then reduced down to a maintenance period where the exercises weren't progressed. As I said, we included the gym program. It was tested in groups of up to 10 residents, and that's one thing that I do need to acknowledge. We could do that because we had 5 pieces of high-tech seated resistance training equipment. 5 of them could sit down and do individual exercises where you just pop a card in and it pops up and says, hello Barry, for example. Not that Barry would have come because it's a group, but hello Barry. And it would have automatically adjusted the sets, reps and weight to his individual prescription. So 5 of them were sitting there doing those while the other 5 were up doing high challenge balance. So that's why it was cost effective, I think. It depended on the group. So that if it was a high cognitive impairment, high level of cognitive impairment, then I usually had one person per three. They weren't physios though, they were therapy assistants. Yeah, one per three. 3 people, yeah, usually 3 people in a group of 10, yep. And if it was a non-cognitively impaired group, it could be 2 therapy assistants. So, as I said, they did 2 to 3 sets of 8 to 12 repetitions. In this trial it says 10 to 15. More contemporary strength training says 8 to 12. So that's what we're doing nowadays, beyond Sunbeam. It was moderate to somewhat hard resistance. So I'm going to talk through that a bit more for the clinicians in the room so you know how to prescribe. And the balance was high challenge balance. These are the exercises that were included in the Sunbeam program. We did knee flexion and extension with weights or low. In the trial, it was using the HER equipment. Since then, you can still do the same program using ankle weights and resistance bands and that sort of thing, and I'm going to give you that sort of recipe, which remember you have to individualise for the person in front of you. Leg press, hip abduction and adduction, plantar flexion. Triceps we did either sitting or standing. Shoulder girdle retraction and external rotation, so that's this type of movement with a band like so, which actually I put in mainly because I wanted them to not be able to hang on to anything. It was more of a balance exercise. And rows in seated or standing. So there is a video which I'll give you the link to after we finish here on how to perform these exercises if you don't have a fancy gym. So each exercise is then prescribed so that the person, when they've done 8 to 12 repetitions at whatever load you've given them, they should be saying it's moderate to somewhat hard resistance. And I'm going to show you the Borg scale in a moment. So you can see here we use resistance bands as well in the scaled up version of this that I spoke about briefly in the morning session, but we use the same exercise principles. So each exercise is individually prescribed using a resistance where the person says after 8 to 12 reps it's somewhat hard using the Borg scale that I'll show you in a minute. The balance we did static feet side by side, semi-tandem or tandem, reaching outside the base of support and recovery steps. But the observation during Sunbeam trial is that people like doing the gym stuff and they found the balance stuff boring. It's like, okay, so we know, and then subsequent, so the Sunbeam data collection finished in about 2016 or 17, and after that we had to come up with ways to make people want to keep doing things in the places where I was working. This is separate to the study. So the students and I have been working on balance with flair. It's talking to people about what they used to do, what they like to do, what they maybe never got a chance to do but they'd love to have a go. So the fellow on your top left there always wanted to try boxing. So he was wheelchair bound when we started. We used the strength program to get him back on his feet, and then the balance program started with the feet side by side, semi-tandem and tandem, and then the recovery steps and so on. And then we moved on towards having a person behind him and a person in front practicing some boxing moves. And now he's at the point where he has actual mitts. We had to keep making it interesting. The lady at the bottom there has a Nerf gun with a target, and she also shoots me when I walk past, hence the cheeky face. There's been dance groups. We work with Leisure and Lifestyle, got the football table in the Leisure and Lifestyle budget. You can see the fellow's got up out of his chair there to help his electric chair, if you don't mind, wheelchair, to help assemble the thing, and then they have to stand up to be able to play it. I do lots of therapy, balance therapy as exercise in disguise, I like to call it. So there's dance groups. I'm not going to talk too much about dance because Gwen's going to take that role later on this afternoon. But I've recently taught a 101-year-old lady how to salsa. So it's not about the dance per se. It's about finding things that will encourage a person to do high challenge balance time. I'm trying to get as many minutes of high challenge balance up as I can in the week. And whatever I can do to promote them to want to spend time in high challenge balance exercise positions is whatever it takes, basically. So for one person it'll be boxing, for another it'll be therapy gardens. When I got the therapy gardens into the villages in which I work, I made them too high to be able to reach from a wheelchair. So you had to stand up. And then you put the implement slightly out of reach, so there's a balance component. So this whole exercise and disguise thing is what I think really works for the balance component. So the study was used, I touched on this previously, as the Allied Health Group Therapy Program. That was the contact from the government, well, actually, it wasn't from the government. I contacted them. So I heard from the researchers that they were thinking they'd like to implement the Sunbeam program into the homes that had COVID in them during 2020. And I thought, oh, that's exciting. And then I thought, what about if they make it a political exercise or a marketing exercise and just do any old thing as an exercise program and don't include individualised resistance and high challenge balance exercise and pour all these resources in because it makes the politicians look good, but it doesn't actually have a clinical effect. So I just took the bull by the horns and emailed the Chief Allied Health Officer and said I'd like to support to make sure it was on track with best practice. And they, what do you know, I got a phone call. That's when I got the phone call. And they said, can you help us put it together? So that was the Sunbeam protocol developed that you could perform with or without the gym. So that's a lot what I'm talking about, that list of exercises that we spoke about and how to prescribe them using best practice principles. The staff ratio with a gym is 1 to 10, was for this program. So this is not a falls prevention program. It's 1 to 10. This was getting people back on their feet. So it was the previously ambulant ones. And without a gym, it was 1 to 4. And that was physio every time. They did have 2,500 residents and it was shown to be effective. They only measured physical performance, though they didn't measure falls because that was their primary outcome. So that report has been submitted. The evaluation said it was effective. The key indicators were you could have therapy assistance because it's really expensive to have a physio do 2 hours a week with groups of 4 people. It's not sustainable. So we looked at doing that with therapy assistance so physios, EPs or OTs prescribe the exercise using the principles I've talked about, and it is rolled out using therapy assistance. These are all recommendations currently sitting with the Minister, but there's been a change of government and we don't know exactly whereabouts on the list it is in order of priority. I don't need to talk to you about this because we've been hearing it all morning. There's such strong evidence for exercise as best practice, and that includes for your oldest old. There's also evidence for exercise as best practice as a pain management strategy. So all those people that were on the 4B or 4A program in the past can be offered exercise as best practice, and you get the side effect of hopefully improving their mobility and reducing their falls rate as well if you give them the right type of exercise. So transitioning to a new model, I recommend, and what I've done, I've just started working with an aged care provider called the Whitten Group, and we've been working on transitioning people who were previously on the pain management program across to an exercise-based, initially pain management, but also falls, mobility and falls prevention program. So we were offering exercise-focused pain management. So you can imagine that people that were previously getting massage 4 days a week might be a little bit resistant to going across to exercise. That's one of the barriers. However, now that nobody moving into a residential aged care is being offered massage 4 days a week, that problem will become a time-limited issue anyway. The step 2 is to offer the evidence-based allied health services and the skill set of the existing allied health staff to all those people who were not on the 4A and 4B list. Anyone who's worked in residential care knows that sometimes we were asked to go and massage somebody 4 days a week whose knee pain wasn't very bad, but it helped with their funding. And right alongside us is someone who didn't have pain, but they really needed our help and they weren't on our list. Now under ANAC, we can see both. Once again, individually prescribed using best practice recommendations and taking the person's diagnosis, their comorbidities and their goals into consideration. So confidently prescribing exercise, and that's not necessarily our skill set now. If you've been working for a long time in residential aged care, you might not feel very confident about how to prescribe the best practice exercise program. But really it starts with knowing the person in front of us. When you do your next initial assessment, you find out, I loved that idea that you spoke previously for Barry, that he doesn't like group exercise. We need to be knowing our individual residents at this level. Sunbeam's not a cookie-cutter approach either. It's a set of guiding exercises that you have to match to the person and his or her goals and their abilities and their conditions. There are so many things we can change. We've had the student program, and I've really helped a lot of people get out of wheelchairs who live in residential care homes. They were only in the wheelchair because they didn't have the opportunity or the skill set on how to get themselves strong again, and we weren't allowed to do it under the previous funding model. But we really have made a difference there. And once we identify what can be changed and improved, we have a chat to them about what they'd like to do in terms of their exercise. This is included for a reason, which I'll tell you in a minute. These are all people in their 90s, the frequent fallers. Love this one, waits for the camera and start. So you can see here that these are trial participants, I was able to get them sitting on the machines, they're quite safe on the machines, and focus on the one-to-one work for the high challenge balance. This is with a cognitively impaired group. I'm teaching him the grapevine. Step out, in front. What? Yep. In front. Step out. Together. In front, out, behind, behind, behind. Out, in front, out, behind. No, not for him, but for some I do. But I just have to stay close. Tandem walking. I just want to give this example of where this type of program can change a life. So I met this, I have permission to use his name. I met Ian when he was 80. He was born with cerebral palsy. It's unusual to find people 80 with cerebral palsy. He had contracture of his right arm and an internally rotated, contracted right leg as well. And he was walking when I first met him, quite hunched over with with a four-wheel walker, and he used to lean on the handles because he couldn't stand up tall. And we started doing exercise together before Sunbeam was a thing, and I could see changes in him early on. Then time went on and I took off and did the Sunbeam trial in other places and came back, and he was back to bent over on his four-wheelie walker. So he was one of the first people who put his hand up to volunteer to be a trial participant, and then I wasn't sure whether they'd be randomised to receive the exercises or not. Thankfully he was. Then that facility that he was in went on to purchase the gym and keep it going after the Sunbeam trial left. So that was a 10-year period. I went back and saw him when he was 90. And when he was 90, he was walking tall. And his family said to him, we'd like to get you... he had no children, never married. His family called him Unc, short for uncle. And so he got a message, Unc, we want to take you on a cruise for your 90th birthday. And he was excited, and that meant family came from far and wide. And one of the family members rang me and said, can we please use a facility's wheelchairs in case Unc needs some help around the boat? And so I got a little collapsible one. And when they came to pick him up, they were flabbergasted that he walked out so tall. And he came back and I said, how'd you go with the wheelchair? And he said, I didn't use it, but I pushed some of my relatives around in it. So the current challenges are the reduced hours. People who used to do massage don't necessarily want to do exercise. We need a culture change in the facilities. Remember the nursing staff as well. They may have never seen what physio, OT and EP can do. If they've only ever worked in the hospitals and in residential care, they've only ever seen us either doing passive treatments or doing what we can do quickly to free up the bed if you're in the hospital. They haven't seen the long-term rehab effects. There's also an issue with the change in the workforce confidence, our own confidence. So it's really good to see you here, and hopefully you can use some of the things you've learnt today about best practice exercise. At Whitton, we've implemented this program without a gym. The exercises are tailored. They had the option to start one-on-one and then proceed into a group program. One of the residents there said that he used to have pain every day in his neck and shoulders, and now it's gone with the exercise program. He had poor balance, he was a frequent faller. He saw results very quickly and he wished he'd started it many, many years earlier. So there's the new quality standards coming out where the number one standard is they're going to have to report on how many people lost their mobility. So we're about to become important again, even if we're off the radar at the moment. And maybe there'll be some recommendations coming from the group therapy program, and that'll be a wait and see. If you'd like to find out how to do those exercises in more detail, there's a video I produced for the Department of Health. If you just look up Allied Health Group Therapy video, instructional video, it's about a half hour and it'll go through in more detail how to provide the exercises. And that's me finished. 2 o'clock, are you proud? Thank you.
Thanks, Jenny. I always enjoy listening to your presentation and anything that's driving improvements in aged care. And just to think that people, the older they get, you can still make a difference in their lives. And I think that's really a refreshing message. And that actually is a very powerful message that we actually could put in front of our politicians, demonstrating how lives can be improved, their quality of life can be improved. So congratulations and thank you for the work that you're doing to be vigilant there with the Commonwealth arguing for the case about getting more effective intervention happening.